Good afternoon, everyone. I'm your host, Raj Bajaj. Welcome you all to AIOC 2021 virtual conference. To begin with, I'd like to invite our chairperson, Professor Akma, co-chairman, Dr. Tariq, chief guest, Dr. Awa Hussain, special guest, Professor Md Shafaruddin Ahmad. Welcome, sir. I'll also like to invite our panelist, Dr. Mahbur Rahman Chaudhary, Professor Ashraf Syed, Professor Md Abdul Kalam, Dr. Md Shaukat Kabir, and also I'd like to invite our moderator, Dr. Md Mostaq Ahmad. I welcome you all, sir.
Okay, Dr. Mustaq, yes, you can take over and you can start your program.
Thank you very much.
Introduce all the chairperson and the panelists and others. Again, please introduce and start your program, please.
Okay, thank you. We'll start our USB session. Now I invite Professor Ashraf Syed sir to give welcome address to this session. Ashraf Syed sir.
Probably he's still not there. You please introduce our chairman, Professor A.K.M. Muqtadi and Professor Shafuddin Ahmed sir. They are present here.
Respected audience.
I'm Professor Muqtadi. Hello.
Hello, sir. Yes, sir.
Can you hear?
Yes, sir. Yeah.
Yes, sir. You're audible.
Respected audience, very good evening. At first, my gratitude and thanks to the Ophthalmological Society of All India Ophthalmological Society for giving us opportunity to this prestigious virtual platform. This session will be chaired by Professor A.K.M. Muqtadi, President Ophthalmological Society of Bangladesh, and also Professor Aba Hussain, President-elect Asia Pacific Academy of Ophthalmology, and Professor Shafuddin Ahmed, Vice Chancellor, Bangabandhu Sheikh Mujib Medical University. He was former President of OSB for 3 consecutive sessions. Ladies and gentlemen, today's co-chairman is Dr. Tariq Reza Ali, Secretary General Ophthalmological Society of Bangladesh, and convener Professor Ashraf Syed, Chairman, Scientific Subcommittee, Ophthalmological Society of Bangladesh. Our learned panelists are Dr. Mahbur Rahman Chaudhary, Professor Abdul Kader, and Dr. Shaukat Kabir. Ladies and gentlemen, now we will start our speaker sessions. I like to invite Dr. Shyamal Kumar Sarkar, Assistant Professor, Department of Neuro-Ophthalmology, National Institute of Ophthalmology and Hospital. He will talk on atypical optic neuritis, what's new. Dr. Shyamal Kumar Sarkar.
Thank you, sir. Thank you. Just a minute, sir. Desktop. Full screen.
Shamal,
Sir. Yes, sir. Yes, sir. Yes, sir. Just a minute, sir. Thank you, sir. Greetings from Bangladesh to the all foreign faculties of AIOS conference. Respected chairpersons, co-chairperson, convener, honorable panelists, and moderator and learned audience of virtual conference. Very good evening to everybody. I am Dr. Shyamal Kumar Sarkar. Welcome everybody to my presentation. Atypical optic neuritis, what next? Optic neuritis is an intrusion of the optic nerve, mostly affect the young adult and the middle-aged female. It is about 31% of the total optic neuropathy of this age group. Usually, this optic neuritis present with central blurring of the vision with or without pain, color vision defect, REPD, central or centrocecal scotoma, normal optic nerve head, or hyperemic disc swelling, and MRI, engorgement and enhancement of the optic nerve. This is the well-known classification of the optic neuritis, ophthalmoscopic and etiological classification. Another classification, it is a clinical classification most widely used nowadays. And another entries of the optic neuritis, that is typical versus atypical. Before going to my topic, I want to highlight some points of typical optic neuritis. This is the patient present with sudden painful visual loss in right eye with right eye hyperemic disc swelling, and on MRI there is no demyelinating lesion in the brain MRI and optic nerve enhancement and engorgement. Without treatment, after 30 days, best corrected visual acuity in right eye 6/9. Patient under follow-up and observation. This optic neuritis is most likely idiopathic cause or due to para-infectious cause because history of flu-like illness 2 weeks back. Another patients having severe visual loss, painful visual loss in the left eye, but optic nerve head is normal. But in MRI, there are demyelinating lesion in the brain parenchyma. In the CSF study, the oligogonal band of IgG is positive. So this optic neuritis is due to multiple sclerosis. Patient treated with IV methylprednisolone and immunomodulator, and after 3 months follow-up, visual acuity nearly normal, that is 6/9 in left eye. These two cases are the example of the typical optic neuritis, where subacute or acute onset of painful unilateral visual loss, normal to mild hyperemic disc edema without hemorrhage and exudate, usually have good visual recovery with or without treatment. Now, atypical optic neuritis. A male patient present with severe bilateral painless visual loss in both eye and bilateral disc swelling is there, and the MRI, there are no demyelinating lesion in the brain parenchyma and spinal cord. On the serological test, anti-NMO or anti-aquaporin 4 antibody is positive. After treatment and 3-month follow-up, vision in the left eye is 6/24 and partial optic atrophy in the left eye. So this patient, this bilateral optic neuritis to anti-aquaporin 4 positive NMOSD disorder. And another patient, sudden visual loss, painful visual loss in the right eye with mild disc swelling in right eye, and in MRI there are demyelinating lesion in the brain parenchyma. This is not like the demyelinating lesion of multiple sclerosis. Patient having same history, same attack in the left eye 2 months back with weakness of the limbs and mixed problem. And serological test, anti-myelin oligodendrocyte antibody is positive. Patient treated with IV methylprednisolone and immunosuppressing agent, and after 3-month follow-up, visual acuity 6/9 in both eye with normal optic nerve head. So this bilateral sequential optic neuritis most likely due to NMO positive NMOSD disorder. Another patient present with painful visual loss in the right eye with disc swelling, and another eye mild pallor of the disc. MRI is normal, no demyelinating lesion. Patient having same history, same attack, repeated attack in the left eye when stop the treatment by steroid. The relevant investigations like anti-MOG antibody, anti-NMO antibody, even MRI scanning of spine is normal. With treatment of the steroid, patient is well. And after 3-month follow-up, visual acuity in right eye 6/9 and left eye 6/18. So this steroid-dependent optic neuritis, bilateral sequential optic neuritis, most likely due to chronic recurrent inflammatory optic neuritis. And another patient, severe visual loss in the left eye, but optic disc is normal. No demyelinating lesion is there. Patient is the known case of the SLE. ANA and anti-CCP antibody positive, anti-double-strand DNA antibody also positive. And after 12 weeks, best corrected visual acuity is PL, no improvement of the vision with treatment. So this, and pale disc in the left eye. So this RBN is due to systemic autoimmune disease, SLE. And another patient, the painful visual loss in right eye for 5 days, and no sense in the no demyelination in the brain MRI, but only mild enhancement of the optic nerve sheath. Here, all investigations are negative, but antinuclear antibody is positive. Treated with systemic steroid, and after 3-month follow-up, visual acuity in the right eye in 6/18 with mild pallor of the disc, and this patient is diagnosed as autoimmune optic neuritis. So, out of 5 patients, 4 patients having mild to moderate degree of optic neuropathy in follow-up visit after treatment in these atypical cases. So atypical optic neuritis are the heterogeneous group of disorder presenting features suggestive of the inflammation of the optic nerve, present with unilateral, bilateral, or sequential painful or painless severe visual loss. Normal disc to severe optic disc edema with or without hemorrhage and exudates. Continued worsening vision over weeks or months. Poor visual outcome if not diagnosed and treated timely. The examples I already discussed in my scenario. Now the mimickers: ischemic optic neuropathy, acute toxic optic neuropathy, compressive optic neuropathy, lever-headed optic neuropathy, all are the mimickers of the atypical optic neuritis. It must be excluded by the appropriate history, examination, and investigation. Now workup. For diagnosis of the atypical optic neuritis, need demographic profile, detailed clinical history, neuroocular workup, and complete neurological assessment. And investigation. This is the mainstay of tools for diagnosis of the atypical optic neuritis. It is not only important for establish the diagnosis, but also exclude the other differential diagnosis and mimickers. Now treatment: IV lethal prednisone 5 to 7 days, followed by oral steroid and immunosuppressive therapy longer period. In acute phase of disease, needed plasmapheresis and IV hemoglobin, and essentially refer to neurologist, rheumatologist, and internist for multidisciplinary treatment. Challenges: lack of awareness of the patient, lack of investigation facilities. In the all corner of the Bangladesh, the investigation facilities are not available in the big city. Financial constraints, maximum of the tests are costly, and lack of multidisciplinary practice in the challenges of diagnosis of the atypical optic neuritis. Now, my message: atypical optic neuritis can have devastating visual outcome. To improve or stabilize the vision, it is crucial to make the correct diagnosis and appropriate treatment in conjunction with neuro-ophthalmologist, neurologist, and rheumatologist. I am grateful to my patients, my institute, National Institute of Ophthalmology, OSB, and AIOS for giving me the chance, and my teachers, Professor Abha Madam, Professor Muqtadi sir, Professor Sharfuddin sir, and others, honorable panelists, my team members, Arvind Eye Care System, and Green Eye Hospital. Thank you. Thank you, everybody.
Thank you, Dr. Shamal Kumar Sarkar, for a nice presentation. Now I invite our panelist, Dr. Shaukat Kabir, Associate Professor, Bangabandhu Sheikh Mujib Medical University, to sum up the presentation. Dr. Shaukat Kabir, please.
Thank you, Dr. Mukhtar. Can you hear?
Yes, you are audible.
First of all, I would like to thank the All India Ophthalmic Society for giving us the opportunity to join a joint meeting with them. And then I'd like to congratulate Dr. Shamal Kumar Sarkar. He's a youngster in neuro-ophthalmology. He explains the details of the atypical and atypical optic neuritis, because if we untreat this optic neuritis, it will be devastating. So we need joint collaboration with neurologists, rheumatologists, and other facilities, and we also need the appropriate tailored appropriate investigation for diagnosis, the other differential diagnosis. So I again congratulate Dr. Shamal Sarkar for nicely presenting the case scenario, and I think it's a wonderful presentation. Thank you, Dr. Mustaq.
Thank you, Dr. Shaukat Kabir. Now I invite Dr. Rashid Alam, Assistant Professor, Islamia Eye Institute and Hospital. He will talk on Fuchs endothelial dystrophy with cataract, how to overcome. Dr. Rashid Alam, please. Dr. Rashid, please share the screen.
Dr. Mustaq, probably I didn't see Dr. Rashid here. Would you please ask other person to present, and if Rashid comes, can present later?
Okay. Now I am the speaker. Ladies and gentlemen. Okay, now I am the, yes, Rashid is here now, I see. Rashid, can you hear me? Rashid, unmute please. Okay. Rashid, unmute please.
Okay, sir. Can you hear me, sir?
Okay.
Yes.
Okay.
Thank you.
Start.
So please start with your screen sharing. We are already a bit late.
Sir,
Hello, I've come back.
Welcome, madam. Rashid,
sir.
time is going on. You should share your screen.
Okay, sir. Sir, can you see my screen?
Not yet.
Not yet?
You are audible, not screen not visible.
Okay, now.
Yes. Okay, yes. Continue. Okay, see you continue.
Thank you very much, sir. Thank you very much for inviting me. I really like to thank All India Ophthalmology Society and OSB for giving me the opportunity. So I have no financial disclosure. So every day in our life, we see this type of cataract. In our clinic, we think it's very simple. You do the cataract surgery and the patient is happy next day. But it's not simple always. If you slit the beam and examine meticulously, you can see the cornea. In the layer of the cornea, there is something wrong in the endothelium. And if you slit the beam and see, there is a corneal gutte, and which is found in Fuchs endothelial dystrophy. So for that reason, you can do the specular, and obviously there is a dropout in the corneal endothelium. You can see the cell density is low, and the corneal thickness is getting much thicker. And in the post-operative, there is a surprise. The next day, you do a phaco, and the picture is like this. So you're thinking, what went wrong? The phaco is being very good. No, there is uneventful, and the time has been hardly 10 minutes, but still there is a corneal edema, and this patient comes to you all the time, and eventually he will develop the pseudophakic bullous keratopathy. So Fuchs endothelial dystrophy, in 1910, Fuchs initially described the bilateral corneal stromal edema and epithelial edema in elderly patients. Fuchs endothelial dystrophy is slowly progressing disease with initial onset with 5th through 7th decade in life. The initial manifestation of Fuchs endothelial dystrophy is in corneal gutte. And endothelial transplantation is treatment of choice for the patient of Fuchs endothelial dystrophy. The American Academy of Ophthalmology guidelines suggest that endothelial cell count less than 1,000 should raise concern about the possibility of corneal decompensation with intraocular surgery. They also suggest that corneal thickness is over than 640 micron, increase the risk of corneal decompensation in cataract surgery. So I'm going to present two cases today. A lady of 43 years came with the dimness of vision. Her vision was 2/60, and she had a dense cataract with that is corneal gutter in the corneal endothelium. So the cell density was like 753, and the thickness is like 659. And the other way was quite a bit normal. So we decided to do DSEC because the donor she got was very young donor. So we are very, for the young donor that the scroll been very tight, it's very difficult to do the DMEC. So we decided to do the DSEC. So this is a video of DSEC. I'm doing normal conventional, that is phacosurgery first, doing incision and capsular rhexis. You can keep the rhexis a bit smaller. In that case, it's in standard size. And then hydrodissection delineation and getting the cataract, that is nucleus removal by the stop and chop technique. I divide into 2, then 4, and eventually, emulsifying all the quadrants one by one. Then the cortical clearance. And I always use a hydrophobic lens in these cases with the help of, that is BSS solution. The cataract is been into the bag. So with the help of AC maintainer, I'm doing the decimeter axis of 8 millimeter. And you can see decimeters is coming out. And you will check the decimeters whether any tag left or not. Then with the, I have done the manual dissection of the DSEC, and with the pull-in technique, that is the Busin glide, I'm introducing the graft into the antechamber. So after that, when the graft is in center, you secure the wound. You don't want to lose the graft, and give an air bubble into the AC to attachment of the posterior graft into the corneal stroma. So eventually this patient, after 6 months, she's doing fantastic. Actually, her cornea is very clear. She's very happy, and I'm also very happy. After 6 months, her vision is like 6/9 with a little bit of hyperoptic shift as usual. And you can see the OCT, the graft is being, that is attached very nicely, and she's surviving with the 1500 cell. So this is the second case, a lady of 48 years with dimness of vision. This is a case of more advanced Fuchs, and I've decided to do the DMEC. So for the DMEC, you need to prepare the DMEC first, that is graft first. So scoring and 8 millimeter graft creating. I always do the F stamping for the good orientation, right orientation, and the 8 millimeter graft is ready, and it is double scroll, so I've stained it. Now with the, as the cornea was hazy, I just removed the epithelium, did the rhexis, but as the pupil was very small, I used the, that is iris hook for the phacoemulsification. With the stop and chop technique, I removed the, that is the cataract, and then put the hydrophobic lens into the bag. And then as the pupil, the rhexis was very small, I just enlarged the rhexis to the desired size, then removing all the, that is iris hook, constrict the pupil with the pilocarpine, doing inferior PI because of that postoperative pupillary block to prevent that. And with the help of AC maintainer, I'm doing the decimeter axis. You can see the decimeters is coming out with the reverse Sinski. So all the decimeter axis is done, and it is taken out. So I've taken the graft in the injector and introduced into the antechamber, and started unfolding the graft with the tapping. You can see the F mark, that is the graft has been oriented correctly. So I've given the air bubble, and then the BCL is given to finish the operation. So she's been doing very well for 1 year or 3 months, and her vision is like 6/9. Although she's having some posterior capsular cataract, that is PCO. So as the vision is good, I haven't done the YAG. She's doing good. So in my conclusion, I want to say that every cataract case, you have to examine properly, slit the beam, do the cross section of all the layers of the cornea, look for any pathology in the endothelium. If you're not convinced enough, you can surely do the specular microscopy, anterior segment OCT to help the diagnosis. So in what I do in case of Fuchs and cataract, I do the endothelial keratoplasty triple, especially when the cell density is less than the 1000 and that is the thickness is more than 640 micron. So thank you very much. I like to give my gratitude to Vikash. He is my mentor and all the team of the Cornea of Ispan Islamia. Thank you, sir, for patient hearing.
Thank you, Dr. Rashid Alam, for presenting very complicated cases. Here I see Professor Abha Hossain, President-elect Asia Pacific Academy of Ophthalmology. She joined with us. Welcome, Madam. Now I request Professor Abdul Kader, Head of the Department of Cornea, National Institute of Ophthalmology. He is former Secretary General of OSB, to share your experiences regarding Rashid's topic.
Thank you very much. Am I audible?
Yes, you are audible, sir.
Thank you very much. I like to thank and congratulate Dr. Rashid Alam for his nice presentation. Good evening, everybody, and my gratitude to the organizer of 79th annual meeting of AIOS as well as Ophthalmological Society of Bangladesh for including me in this great session. Dr. Rashid Alam presented his paper very nicely, and his presentation was very good and illuminating. He has shown 2 videos. First one is decimates membrane endothelial keratoplasty as well as cataract surgery, phacoemulsification, and posterior chamber IOL implantation. His surgery was very good and demonstration is very good, and I congratulate again him. And another video on decimates membrane endothelial keratoplasty in small pupil as well as phacoemulsification. Both surgeries are very good, and I again congratulate him. In Fuchs endothelial dystrophy is a dystrophy which is audible. Me?
Yes, you are audible, sir.
Fuchs endothelial dystrophy is one type of dystrophy which is present in later life, as usually presented unequal presentation in either eyes. The Fuchs endothelial dystrophy is usually associated with cataract as well as glaucoma. So surgery is very difficult. When there is cornea is very much edematous and cornea is endothelium is unhealthy, we go for endothelial keratoplasty as well as cataract surgery or glaucoma surgery if needed. In such cases, it is very much important to see the endothelial count. Not only the count, but also the quality of endothelial cells. So 1000 count is not sufficient to maintain that normal healthy cornea after phacoemulsification. So this is very much important. Another thing is quality of cornea and quality of surgery and quality of phaco machine. All things are needed to good outcome of phacoemulsification in Fuchs endothelial dystrophy patient who is very in advanced stages. So another thing is important is post-operative outcome and post-operative follow-up. In such cases, there is rise of intraocular pressure. So post-operative follow-up, you must follow the intraocular pressure as well as position of the graft. Sometimes there is detachment of the endothelial keratoplasty. So this is very much crucial for first few post-operative weeks to follow up the patient. Thank you very much. Thank you everybody for including me here. Thank you everybody. Assalamu alaikum.
Thank you, Professor Abdul Kader, for sharing your experiences. Respected audience, now I am the speaker. I just share my screen. Sure.
Mustaq, share your screen.
Yes, sir. Just a minute, sir.
Launch meeting. Launch meeting. Yeah.
ডেস্কটপে যাবো করো ওকে
No.
ওকে স্যার
Yes.
Okay, you can
Yes.
start.
Very good evening, respected chairperson, panelists. At first, my gratitude and thanks to All India Ophthalmology Society to giving us chance to join this prestigious virtual platform. My topic is flex has advantages over manual phacoemulsification. I am Dr. Md Ahmed, Associate Professor, National Institute of Ophthalmology. I have no financial disclosure. History and nationality, laser have been utilized in cataract surgery since the 1970s by Krasnov. Accuracy and precision in cataract surgery becoming concerned with premium intraocular lens depends more on precise centration for optimal performance. From the second, laser allows to precise cutting of tissue with minimal collateral damage. It provides an ultra-fast burst of energy which acts by photodisruption of the tissue. And it generates plasma, which causes a shock-wave cavitation and bubble formation. The bubble expands and collapses, leading to separation of the tissue. FDA approved femtosecond laser for LASIK in 2001 and for cataract surgery in 2010. Optic Medica catalyst uses in our institution. Important factors for good surgery and perfect visual outcome depends on well-constructed incision, good capsular axis, using less phaco energy, and managing astigmatism. Sometimes manual clear corneal incisions may cause imprecise tunnel length and geometry, and which causes wound gap and increase the chance of infection and also causes surgically induced astigmatism. Shows some improper incision causes defective wound healing, produce wound gap, which significantly decrease good surgical outcome. There is a side port and main two-plane incision which should be well constructed to self-sealing, otherwise may cause complication. In some studies shows that and prove that effective lens position is very much important for proper accurate visual outcome. It should be round, centered, and just smaller than the IOL optic diameter. And femtosecond laser, by femtosecond laser, it is possible to do very good capsular axis. This is normal phaco capsular axis, may irregular and run out. Especially in white cataract, it is very difficult to do good capsular axis. To make it center, round, regular, and adequate in size. Sometimes it is run away laterally, there is peripherally extension occur, which causes posterior capsular rupture and may very difficult to do continue phacoemulsification, may need to convert to small incision cataract surgery, and may cause a devastating condition, posterior capsular rupture. In that cases, some surgeons want to do double rhexis, which is actually need very skilled surgeon, very difficult to do for that cases. So femtosecond laser is very good for do proper capsular rhexis. Lens fragmentation. Lens fragmentation is very important role to prevent complication. It is very crucial to break the nucleus and save power and time for good surgical outcome and prevent complications. Some studies shows in femtosecond laser surgery, 51% reduction of average phaco time and 43% reduction of effective phaco time in case of femtosecond laser surgery. So it is when it is tremendously help to clear cornea just after operation. In hard cataract, during scalping, need high energy and need more time and very difficult to break it and may causes some complication like corneal edema and may delay the patient rehabilitation. Here is another one, grade 3 plus cataract, forming the central crater, which also need very high energy and more phaco time is needed, more chance of posterior capsular tear, corneal edema, and delayed patient rehabilitation, which causes decreased patient expectation. So femtosecond laser offers a new level of precision and reproducibility in ophthalmic surgery, help to optimize the capsular and corneal incisions. The steps are capsular rhexis, lens fragmentation, main incision, side port incision, and corneal relaxing incision. First step is docking. It needs precise docking for optimum laser firing. Precise incision is possible by femtosecond laser. This is patient summary. Capsular rhexis is first important step for phaco surgery. No capsular rhexis, no phaco. It causes very precise shape, size, and centration of the rhexis, which causes symmetrical uniform fibrosis and healing, leading to consistent effective lens position, which is very important for postoperative visual outcome. This is comparison between manual and femto laser assisted capsular rhexis. This is very round central capsular rhexis with good position of the IOL in comparison to manual phaco. So in case of femtosecond laser surgery, nucleus management need very less energy, scalping is steep, less effective phaco power, so less compression is produced, so less complication. This is marking for femtosecond laser. Here showing capsular rhexis. Then after docking, it's showing OCT images of the anterior segment. Then laser is started, capsular rhexis, quadrant, softening of the nucleus, and incisions is given by the femtosecond laser. After that, very good circular rhexis and softening of the hard nucleus and very easy to remove. Very easily remove nuclear fragments here. And another video, very center round capsular rhexis with softening of the hard nucleus and who is easily removed by vacuum, no need of power, less effective phaco time, and so visual rehabilitation is very good and patient expectation is fulfilled. This is another video. Okay, some study shows that in femtosecond laser surgery, lower effective phaco time, less endothelial cell damage, and less edema after surgery. Contraindication are small palpable aperture, shrunken eyes, large nose, and small pupils, along with other contraindications. Advantages of flex: better quality of incision with reduced induced astigmatism, increased reliability and reproducibility of the capsulotomy with increased stability of the implanted lens, reduction in the use of ultrasound at nucleus management. It is very costly, need very trained staff, need more operating time, and patient expectation is very high. Patient selection should be selected patient with proper counseling. Patient should be motivated with realistic expectation. Need very trained, skilled hand and skilled surgeon. Thank you very much for patient's hearing.
Thank you, Dr. Mushtaq. Am I audible?
Yes, sir, you are audible.
And now I am requesting our respected panelist, Dr. Mahbubur Rahman Chaudhary, sir, Chairman, Bangladesh Eye Hospital, to make some comments about the presentation. Dr. Mahbubur Rahman Chaudhary, sir, please. Dr. Mahbubur Rahman Chaudhary, sir, are you here?
Sir. Unmute, sir, please.
Mahbub.
Unmute, please, sir. Unmute, sir.
Mahbub bhai, please unmute.
Sir, unmute होता होगा, sir, unmute.
Mahbub sir, please unmute.
Host can do this.
Yes, sir.
Yes, sir.
Am I
Now you will be audible, sir.
Yes, sir.
Can you hear me?
Yes, sir.
Yes, sir.
Yeah, sir. Okay. Dr. Mushtaq Ahmed, that was a wonderful presentation. I really enjoyed it. And it shows the best technique that we have in our country and in our parent institute, premium institute. And you have rightfully said that these are few advantages, and definitely we should look into this, because rhexis is the most important thing in phacosurgery. And while we're doing manually, there are chances that it's going to spread, it's going to not be round, and sometimes it goes, extension is there, because in our hand, however expert we are, the chances are there that the rhexis will not be of the optimum size and shape that we desire. But in case of flex, it is predictable, and this is the size and shape can always be consistently reproduced. So this has an added advantage, and we know in phacosurgery, rhexis is the most important step. So if this can be done properly, in the right manner, in the right size, the surgery becomes much easier. And at the same time, one issue with phaco is always the energy that we are using, So flex gives us an opportunity to reduce our energy during phaco. And this also gives proper, what you call, proper care to the endothelial cell of the cornea. And if we can, in case of hard cataract, where a lot of energy is being used, this can be reduced in a good way by doing flex. And at the same time, though we are using toric lenses, but a small astigmatism like 0.5 diopter, this can be corrected by giving aqueous incision. That is possible in case of flex surgery. So definitely this will give advantage over the manual what we are doing. And at the same time, when we are using premium IOLs like toric, multifocal, bifocal, or trifocal, or extended depth of focus lenses, where the expectation is very high. So if you can combine these premium lenses with the flex, the results would be excellent, and the patient satisfaction would be very good. So I really agree with Dr. Mushtaq, what he has said. Flex definitely has an edge over the conventional phacosurgery. Thank you very much.
Thank you, sir, for sharing your experiences. Now I invite Dr. Shamsudduha, Assistant Professor, Department of Retina, Badem Hospital. He will talk on tucking SFIOL is better than tying SFIOL. Dr. Shamsudduha, please.
Dr. Shamsudduha, please start. We can see your slides.
My share screen is visible, sir?
Yes.
It is visible, yes, sir.
Yeah. Good afternoon to everyone. Thank you all India Ophthalmological Society and Ophthalmological Society of Bangladesh for give me opportunity to talk my presentation in this session. I am Dr. Shamsudduha going to present my topic, tucking SFIL is better than tying SFIL. We know that in absence of adequate capsular support, there are many options for intraocular IOL presentation, IOL implantation. These are anterior chamber IOL, iris fixated IOL, tying SFIL, that is sutured SFIL, glued SFIL, and tucking, that is sutureless SFIL. Now we are practicing tying SFIL and tucking SFIL, but question is that which one is better? First, coming to the suture SFIL. Here you can see a picture of suture SFIL. It has some limitations, but one of the serious complication is that long-term suture degradation that causes decenter of IOL or dislocation of the IOL, sudden drop of the vision of this patient. So it is serious for the patient. Now coming to my tucking SFIL, it is sutureless glue-led SFIL, and it is simple procedure. Only 5 important steps in this surgery. First of all, 2 scleral pocket I did at parallel to the limbus, about 3 mm length. Then 2 sclerotomies at the side of scleral pocket, 1.5 mm from the limbus. Then go for main incision, a scleral tunnel or clear corneal tunnel for 3-piece IOL implantation, either it is foldable or rigid IOL. Then haptic externalization with the help of the forceps, and finally tucking the haptics into the scleral pocket. We are using in this sutureless SFIL 3-piece intraocular lens, either it is foldable or rigid IOL. Now to see the video of this sutureless SFIL, that is tucking SFIL, and this is a case of aphakic case. And first I did 2 scleral pocket at 3 and 9 o'clock position with the help of 1.5 keratom. It is 3 mm length, half thickness scleral pocket, about 1 to 2 mm away from the limbus. Two scleral pocket is done. Then go for sclerotomy at the site of scleral pocket, 1.5 mm away from the limbus with the help of 23 gauge needle. 2 sclerotomy is done. This is side port and another port for AC maintainer to maintain the anterior chamber during the surgery. This is AC maintainer. Then go for main incision with the help of 2.4 keratom. This is clear corneal incision, and go for anterior vitrectomy Here you can see witness tag is attached at the pupillary margin. I remove it with the vitrectomy cutter. Anterior vitrectomy is doing. Now oil implantation. It is a 3-piece foldable oil and introduced with the plunger, and it is slowly released into the anterior chamber. And to hold the leading haptics with the serrated forceps, first left-handed haptics with the serrated forceps, and it is externalized through the sclerotomy port. Now leading haptics is externalized. And in same way, tailing haptics also externalized with the help of the serrated forceps. Now both haptics are externalized, that is outside the sclera. Now my final steps to tucking the haptics into the scleral pocket with the help of McPherson forceps. Right-sided haptics is tucked into the scleral pocket, and now left-sided haptics also tucked into the scleral pocket in the same way. In this surgery, no need of suture, and so no tension for suture degradation. This is centered, oil-centered esophageal, sutureless esophageal, and no tension for IOL dislocation or IOL decentered. So my conclusion is that as this technique avoids the risk of long-term suture degradation and IOL dislocation or decentered, which is associated with the tying esophageal, but our tucking esophageal may be a safe and simple procedure. So we can say tucking esophageal is better than tying esophageal. Thank you all. I like to special thanks to my teacher, Professor Ashraf Saeed sir. He gave me opportunity to work up this sutureless esophageal at Bardem Hospital, Dhaka. Thank you all.
Thank you, Dr. Shamsuddwa, for nice showing presentation and videos. Now I invite Professor Ashraf Saeed sir to sum up the Shamsuddwa's topic.
Thank you, Dr. Mukhtar. First of all, I'd like to congratulate Dr. Shamsuddwa for a good presentation. SFI is an excellent technique for the aphakic patient needs IOL implantation. Dr. Shamsuddwa also implanted a foldable lens. So the incision size is very small. So the optical difference between these operations and a successful phaco, I think there will be no much difference. On the other hand, this technique is a safeguard for the ophthalmologist. We know the mishap may occur anytime. So I think this is a very good technique. I again congratulate Dr. Shamsuddwa for a good work. Thank you.
Thank you, sir. Now I invite Professor Nujat Choudhury, Professor, Department of Retina, Bangabandhu Sheikh Mujib Medical University. She will talk on ROP scenario in Bangladesh. Dr. Nujat Choudhury.
Am I, is my presentation visible?
Yes.
Yes. Yes.
Thank you, moderator, for inviting me. I'd like to thank All India Society, All India Ophthalmological Society and Ophthalmological Society of Bangladesh for giving me this opportunity to present on the ROP scenario in Bangladesh. Honorable chairpersons of the session, co-chair, respected convener, and respected panelists. We have from time to time given you update about the, given the international community update about the ROP service delivery. The purpose of my presentation is to provide you with the recent steps that we have taken to improve the ROP scenario in Bangladesh. I have no financial disclosure. As we all know that Bangladesh is a very populous country. It's 8th globally populous country in the world. And if you calculate from the crude birth rate and the live births and the number of preterm among the live births, about a decade ago, we calculated that we are whopping more than 400,000 premature births a day every year. 10 countries account for 60% of the world's preterm birth, and Bangladesh ranks 7. That is just to recapitulate the gravity of the situation. Bangladesh has certainly become a lower middle income country. We are going on to become middle income country. And now the NICUs are being established in divisional headquarters. The government of Bangladesh is setting up 64 NICUs in collaboration with UNICEF. But few of those NICUs have ROP screening. So where do we stand today in terms of ROP screening and treatment? In one of our recent publications from Bangabandhu Sheikh Mujib Medical University, amongst our inborn children, 23.7% of the premature children had some sort of ROP. It is not to say that all of them require treatment, but we need to screen 100% of the babies to find out this 1/3 of the baby which are potentially in the line for blindness. This is only the low birth weight babies. What about the extremely low birth weight babies that we are finding these days because of the infertility treatment, because of the improvement of NICU care? Younger and more low birth weight babies are surviving. So we did a research among the very low birth weight and extreme low birth weight babies. Among the very low birth weight babies, 23% had ROP, but among the extremely low birth weight babies, which are quite common these days in NICUs, 44.44% are developing some sort of ROP. And that's almost half of the babies. And among those extreme low birth weight babies, in the same research, we found that most of them go on to develop the serious type of ROP, either stage 3 or even APROP, which we know that within 72 hours to few days, the child will go blind unless we treat the baby immediately. So we did a short situation analysis of where we stand after the National Summit of 2016. LV Prasad Eye Institute retina specialist and Bangabandhu Sheikh Mujib Medical University retina specialist jointly collaborated in the situation analysis. And the purpose was to share the experience that we have learned from a no ROP campaign that we did. That is a neonatologist, ophthalmologist, retinopathy prematurity campaign that we did in Bangladesh and in a peripheral district that is Mymensingh, where one government hospital and one private hospital was under research. So there was a 1-week workshop and there was a pre and post test workshop. This is our methodology of the pediatrician and ophthalmologist. A structured questionnaire was given to decide the knowledge, attitude, and practice, and 2 peripheral units of Mymensingh were visited. So the result that came was dismal. I will not go into detail of it, but this publication is in the Bangladesh BMRC bulletin, came as a short communication. Just see this. Here, number of babies with sight-threatening ROP in the government NICU was 40, among which 38 became blind in 2016. And in the private case, 9 out of 10. So that was a very dismal situation, but that was in 2016. And since then, we have taken many steps to decentralize our service. But the recommendation of that particular paper was that all scaners should have ROP screening, which is not still there in all the scaners. And all our training ophthalmologists should be able to do indirect ophthalmoscopy and should be able to do at least ROP screening. Like we all can do gonioscopy, so they must be able to do indirect ophthalmoscopy and can screen ROP baby. And ROP screening needs to be incorporated in the critical care of newborns in every newborn care center. So other recommendations were curriculum introduction, quality preterm care, training of key personnel, and so on and so forth. The conclusion of that particular paper was that the services that we had at that time in Dhaka needed urgent strengthening, and we needed to disseminate that knowledge and service to district level. So what have we done since then? But even before that, in 2013, BVRS did CME on ROP. There were seminars in 2014 with our Orbis in ROP. There was a week-long training in Bangabandhu Sheikh Mujib Medical University in collaboration with DGHS and LVPI. Dr. Subhadra Jalali, Dr. Padmajan, Dr. Tapush came. We were honored to have them as trainers. And the national summit, first national summit, with all the stakeholders, neonatologists, obstetricians, NGOs, everybody was there in the national summit. It was jointly done with BSMU, DGHS, and Orbis. So now the situation is that in Mymensingh and Chittagong, with the help of Orbis, they have full-fledged functioning NIC service, ROP service, and treating them as well. In Cox's Bazar, with the help of UNICEF, there is a screening service going on. In that deep eye care also, there is screening going on. So decentralization has started. Few are on the way. In 2020, we did another national summit in collaboration with IRD and USAID. And Claire Gilbert, we were honored to have her here with us, and all stakeholders were also there. So that culminated in formation of a national technical committee who were entrusted with the job of developing a CME manual for neonatal healthcare providers, or also a national guideline, which have been formulated, and they are awaiting approval. But we haven't stopped even during the COVID time. We have trained some trained ophthalmologists to become the master trainers, so that they can go to their particular centers and disseminate the knowledge, so that ROP service can be decentralized, which is very important. Bangabandhu Sheikh Mujib Medical University has one of the largest NICUs of the country, which has difficult and most complicated cases sent to us from across, from all over Bangladesh. So we have to, in our ROP center under Department of Ophthalmology, treat those complicated cases. So recently we have done a MOU with Orbis with the aim to turn that ROP center into the National Resource Center. We will be given teaching, training, curriculum development, clinical standardization, and coordination of countrywide ROP networking. We will provide teleconsultations to other ROP hospitals across the country. We will collaborate with other ROP actors in NIO, Islamia, BARDEM, CITC, as well as South Asian and Southeast Asian regional ROP specialists and centers. So in conclusion, we know that we are facing a crisis. A huge number of ROP babies are on our way, and already there we are facing them. We know that we have a long way to go, but I want to spread this news that efforts are underway to eradicate the ROP-related blindness from Bangladesh, and we are working hard for this. Thank you very much.
Thank you, Professor Nujat Chaudhary, for sharing ROP scenario in Bangladesh. Now I request Dr. Tariq Reza Ali to say something about the topic, and please say something for the audience as you are Secretary General of Ophthalmological Society of Bangladesh.
Okay, thank you, Dr. Mustaq and Professor Nujat. As usual, the very nice presentation. You see, ROP or retinopathy of prematurity, we were doing this thing since say at least from 2005, 6, from 2005 probably, we 2004 we were doing ROP service in our small caliber and category. But since 2009, probably we are doing in a better way. And now so many trained personnel in Bangladesh, and every institute, they are taking care of these unfortunate babies. This is a hope for us. And as you showed, that Bangabandhu Sheikh Mujib Medical University will be the central, and it will be, we tell it spoke and hub, central hub and spoke, that maneuver, that all the other centers will be there, and in 8 districts, 8 divisional headquarters, there will be 8 red camps, and Bangabandhu Sheikh Mujib Medical University will be the central part. Everywhere there will be the red camp, the babies that is fundus photographs will be sent to us, and we will take care which babies will need some treatment or not. Those things are very important, and I see that there is a great hope in future, as because government has come forward. That is Bangabandhu Sheikh Mujib Medical University, National Institute of Ophthalmology, other NGOs, other institutes, and finally the government of Bangladesh. They will take care of these babies. So I feel there is a great hope in future. And congratulations again, Professor Nuzhat, for your effort at BSMMU. What you are doing, probably we will overcome someday this problem. Certainly will overcome. And as Dr. Mustaq asked me to tell something as a co-chairman of this session, what I tell that I'm really grateful to All India Ophthalmological Society, especially Dr. Partha, and he showed us, and also the President and Secretary of All India Ophthalmic Society for inviting us in this prestigious conference. Probably I don't know what they will feel, but we tried our level best to fulfill their that is how a better way we can present our scenario. You know that the ophthalmology of Bangladesh is really it is going forward, and we are we are doing better every day, and every year we are doing much better. And of course we are grateful to our Indian friends, our Indian teachers. They are showing us how to improve our ophthalmology in this scenario. I want to thank them. Really we are grateful to our teachers in India. So with these few words, may I conclude my topic, my lecture, and I thank all the presenters who presented today. And another presenter is still waiting, Dr. Muktirani Mitra. I know she will also do much better. She will be presenting on oculoplasty. So I congratulate everybody for their nice presentations. Thank you.
Thank you, Dr. Tariq Reza Ali. Now I invite Dr. Muktirani Mitra, Assistant Professor, Dhaka Medical College. She will talk on orbital sinus mucocele outcome of management. Dr. Muktirani Mitra, please.
Sir, am I visible?
Yes. No, you are not still visible.
I'm not yet visible, sir.
No, you didn't open your
visible.
slides, Mukti. You just, yes, you please open your slides. Your slide share was okay. Yes.
Yeah. Slides are visible. Yes, sir.
Yes, sir.
Is it visible, sir?
Yes. Visible.
Yes, visible, sir.
Yes.
Thank you, sir. Good afternoon, respected panelists and honorable audience. I welcome you all to my talk on orbital sinus mucocele and outcome of management. And I'm most thankful to Ophthalmological Society of Bangladesh and All India Ophthalmological Society for inviting me to share my experience in this subject. And I have nothing to disclose financially. As you know, the sinus mucocele, it is formed by the respiratory epithelium, and it's formed due to poor drainage of the obstruction due to some many causes like infection, inflammations, and so on. Among the all paratha sinuses, frontal sinus is the commonest, that's from which mucocele may arise. This is the second most common is ethmoid, though most of the cases combination of frontal sinus, ethmoid sinus are usually seen. Maxillary and sphenoidal sinuses are very less common to be involved. These sinus mucocele may become complicated when they have extended into intracranial space and also the intraorbital space. And our presentation of the sinus mucocele depends on the involved sinus. In case of frontal sinus mucocele, most common presentation is severe proptosis, and when there is associated with ethmoidal sinus component, then may be associated with the dystopia. And these huge proptosis may lead to exposure keratopathy leading to the loss of vision. Some other less common presentations caused by sinus mucocele, these are muscle imbalance, image distortion, and some less common cases, visual field change and vision loss, though these are usually rare except from exposure keratopathy. And some sinus mucocele may present as other lesions like arachnoid cyst. This is an interesting case of arachnoid cyst treated in our department. This case later diagnosed as arachnoid cyst, later managed by our neurosurgeon colleagues. Now, sometimes from sinus mucus, the content may undergo spontaneous absorption, leading behind a fibrosed sinus mucosa. In this patient refuses further surgical reconstruction. Now, definitely surgery for the sinus mucosa is surgery. Treatment is surgery, and this surgery can be done in both external approach and by the endoscopic approach. And then we usually prefer mucosal removal by external approach, and endoscopic approach is commonly preferred by ENT surgeons and sometimes neurosurgeons also. And this patient with huge frontal sinus mucosa presents with severe proptosis with reduced vision from prolonged and neglected case of mucocele. And after surgery by external approach, good outcome was there, but his vision is remain reduced because of macular scar. And now these are few examples of ethmoid sinus mucocele, extensive ethmoid sinus mucocele, nicely bandaged with external approach, leaving behind no sequelae. Now, from sinus mucocele may pose a diagnostic challenge, especially in case of very early stages. This patient present with mild proptosis and occasional having mild pain. And on scanning, you see there is very less the irregular shadows in the supromedial part of the orbit. So we have planned for further exploration. On exploring, there is a very early case of frontal sinus mucocele. As in early stage, there is no bony covering, so sometimes diagnosis may be missed. This is an interesting case of giant frontomiddle mucocele, and on the neglected case, the after surgical removal by external approach, this patient there's a residual the sequelae of deformity in the frontal bone. This is the third postoperative day. Later on, the eyeball remained its normal position, though the defect in the frontal bone is still there. Now, surgery on the frontal sinus mucocele have their complications also. Recurrence is being the most common complications. Others are vital structure damage, which is most commonly encountered in endoscopic approach. Sometimes there may be biocele formation in postoperative period when there is associated with the infections. And to prevent this, this is an interesting case of recurrence. After doing primary surgery on the frontal sinus mucocele, patient presented with discharging sinus in the orbital roof, and after undergoing several procedures, and after all the cases managed, but through a complicated procedure. This is another case of huge frontal sinus mucocele having several times recurrence, though ultimately the patient was doing well. And for preventing recurrence, the important surgical steps are proper clearance of the sinus content, establishment of the normal drainage by stenting, though we are not using any stenting, and the dead space of the sinus of the mucocele obliteration that may be obliterated by autologous fat graft. This patient presented with the frontal ethmoid sinus mucocele with severe dystopia. That is, patient is having acquired telecanthus. And after planned incision for further reconstruction of the telecanthus, that is reconstruction of the medial canthus, expiration of the sinus content is very important. And this mucocele is having the special characteristics of having multiple septate appearance, that is separated by the thin pieces of bone and associated with the hyperostotic bone. Then after removal of this bony septa, entire sinus mucosa has to be clearly removed out, because if there is remnant of any sinus mucosa, there is every possibility of having recurrence again. And this mucosa has to be nicely carried out, because there should not have any remnant. And after removing this mucosa, the trimming of the hyperostotic bones has to be done to provide almost a near normal appearance. And postoperative drain tube has to be placed there. Though we are not using any stenting for prevent recurrence, these cases are doing nicely without any stenting. For prevent recurrence, we did another procedure. This young lady presented with the hyperostotic lesion in the supromedial part of the orbit, and with in CT scan showing almost absorption of the sinus content, with leaving behind a small hypertrophic sinus mucosa. And after exploration, the removal of cap-like hyperostotic bone was removed. Almost there is no sinus secretions. So residual sinus mucosa was removed, and abdominal fat was taken, and the cavity of the mucosal cavity was filled with the harvested abdominal fat, and this is the post-operative appearance, and this patient is nicely doing well with good satisfaction. Now, in conclusion, we can say that this orbital sinus mucosal pose same diagnostic and therapeutic challenges as other orbital tumors. Treatment is highly individualized because presentation is different, and definitely outcome of endoscopic approach is excellent, but the good and meticulous surgery through external approach may provide a good outcome as well as endoscopic approach. Now, I must thankful to my mentor, my teachers, my department, National Institute of Ophthalmology, where I have taken my training, and also OSB and AIOC. Thank you and welcome to my beautiful country. Thank you.
Thanks, Dr. Muktirani Mitra, for very elaborate presentation. Now I request Professor Sharfuddin Ahmed, Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, to sum up the topic and to say something for the audience as a chairman.
Thank you, Dr. Mustaq.
Yeah.
First of all, I thank Dr. Muktirani Mitra, who has presented excellently. I thank All India Ophthalmology Society and also Ophthalmological Society of Bangladesh, as because, can you hear me?
Yes, sir.
Yes. As because today, this All India Ophthalmological Society has given us all the ophthalmologists for the refractive surgery, for neuro-ophthalmology, for the retina, and also oculoplasty. All the surgeons have shown their experiences by their presentation. Muktirani Mitra, she has presented in such a way that this type of orbital mucocele is rarest, but that can cause a lot of complaint, all the problems. And now you have already learned about the black fungus or mucormycosis, which may be also one of the DD for this type of orbital mucocele. And you
We
see,
did an exenteration yesterday at
yes,
medical college.
yesterday there was exenteration. Yes,
Yes, sir.
for this mucormycosis or the black fungus, there is the exenteration. And I have heard from Ashok Grover that in the last 3 months, they got about 36 patients and 19 patients have to be exenerated. And you see, the Mukti has very nicely operated some cases, as because there is some dystopia, there was some hyperostosis, and you have already seen that in case of this type of mucus or fluid cysts in the orbital sinuses, if it is in the frontal sinus, it will make the eyeball downwards. If it is in the ethmoid sinus, the eyeball will be upwards. And if it is in the maxillary sinus, the eyeball will be inward. In this way, we can also clinically, we can suspect, and then radiologically, we can diagnose this. And I think this type of cases are very much important due to corona complication. And anytime, if there is the proptosis, if there is the diplopia, or also there is the defective vision or immediate loss of vision, we should think of that whether other things like blackness in the nose or in the nasal sinuses, or if there is any continuation with the brain, that can be excluded by our radiological examination, and also our colleague who can also give us the idea from otolaryngologist by their endolaser debridement in the sinus. I thank all the speakers. Along with this, I thank All India Ophthalmological Society of Bangladesh. In future, we hope we will work together physically. And even though this webinar is highly prestigious, because before this, I found Mohipal Shajdev, Namrata Sharma, Lalit Verma, Partho Bishas, all were in the previous session. I thank all of them, and we hope they will also visit in our country, in our conferences in future, and we will work together. And if necessary, our university, Bangabandhu Sheikh Mujib Medical University, will also have some collaboration with All India Ophthalmology Society and other institutes of India. I hope they will also help us. With these few words, Thank you very much for patient sharing.
Thank you, sir. We are at the end of the session. Now I request one of the chairperson, Professor Aba Hussain, President-elect Asia Pacific Academy of Ophthalmology, to say something for the audience. Madam, please.
Thank you, Dr. Mustaq. I'm really sorry that I came late, as because I had a session, that is, I was the keynote presenter there. And after finishing, I just take the apology and come here. Where is my love? And all are sitting here. I miss, I think, one or two speaker. I don't know, as because I have, when I entered at that time, Dr. Rashid starting the Fuchs endothelial corneal dystrophy. It was an excellent one. And the video he shows, the DSEC and DMEC, excellent. I think there are so many participants still waiting here, 63 now, and at that time, 68 like that. So everybody learned a lot. And Kadir has explained it very nicely as a panelist. So congratulations to Dr. Rashid. And next is Mustaq. Mustaq has shown very nicely the flags, and Mahbubur Rahman Chaudhary as the panelist. So he has also explained his experience and tell us all the thing that is very much beneficial for the participant. So thank you, Dr. Mustaq. Congratulations to you, as because you are the member secretary of scientific session, not the member secretary, secretary of scientific session, and you did lot of work to make this session a grand success. So that also goes that. Thank you so much, Mustaq, and congratulations to you. Next speaker is Dr. Samsuddoa. Very nice. He showed that tucking and the tying method. So he showed it very nicely. And also, who was the panelist this time? I missed.
Professor Ashraf Said.
Oh, Dr. Ashraf Said. Yes, I missed. I don't know why. Important telephone was there. That's why. So his presentation was very nice. Thank you so much, Dr. Samsuddoa. And next, the two lovely speaker, the Dr. Nuzhat and Dr. Mukti. Both are doing so nice. Dr. Nuzhat has explained ROP. I think Shubhadra Jalali in India and Dr. Nuzhat in Bangladesh. I will say that Dr. Nuzhat will go up to Shubhadra Jalali within very few years time. Yes, she's doing very good, very well, and she is in the best place, that is in Bangabandhu Sheikh Mujib Medical University, where is the first ever Vice Chancellor, Professor Sharafuddin Ahmed is there. We are very proud of him, and I think that he will take this department to the best level that never been in Bangabandhu Sheikh Mujib Medical University, as because everybody is very giant surgeon, I must say, as because there is Dr. Khalid, Dr. Tariq, Dr. Nuzhat, Dr. Noman, Dr. Joyasri, all are doing very good. And so very proud of Bangabandhu Sheikh Mujib Medical University Ophthalmology Department. And thank you, Nuzhat, for your excellent presentation. And the last, but not the least, Mukti Rani Mitro. So nicely she presented, and so lovely she's looking today, wearing the shari with the very nice tip, looking real, so beautiful. And her presentation is also so elaborate, illuminating. And I miss that Dr. Tariq Reza Ali has explained ROP in so nice way as a panelist and also as a co-chairman of the session. So the last panelist was Professor Sharfuddin, as because he is also oculoplastic surgeon and he explained all the thing. So this is a very good session, excellent session. I should congratulate all the speakers whom I miss, and I attend your one is an excellent one. I think it is world class presentation, and I didn't see as because there are also Dr. Rajit, Dr. Natarajan, Dr. Shubhodhi, they are the chairman and commented on my presentation. It was a very excellent session. I missed that session, but still I didn't feel anything loser as because again from here, my own mother society, that is the Ophthalmological Society of Bangladesh, whom I am very proud and tell everywhere the great platform of Asia Pacific Academy of Ophthalmology. They are always about OSB. OSB always stand the top of the list, top of the score. So now this session, our president, Professor Muqtadir, and our Secretary General, Dr. Tariq Reza, they are doing so actively, very much dynamic leadership within these 2 months. They are doing a lot of things and they will do the best ever and take OSB to a greater height. Now I would like to express my heartfelt thanks to President and Secretary, Honorary Secretary of AIOS for giving us this great opportunity to do this session, and the best thanks or what I say to Dr. Parthush Bishas, as because he worked with his team tremendously. And every day he spoke to every country, so that they gave a session to the SARC Academy. He is repeatedly calling us to give a session, OSB, contact OSB to give a session and all type of this. So that makes the Congress a grand success. So my heartfelt thanks to Parthu and your whole team, and also Professor Namrata Sharma and all others. Thank you so much. Thank you so very much, this team, Professor Muqtadir, Professor Sharfuddin Ahmed, Professor Abdul Qadir, Dr. Tariq Reza Ali. I am saying actually, Professor, I was supposed to tell the Tariq name, and then I stopped today. He will be, our Honorable VC is here, so he will be professor within very recent, as because I think he deserves it.
Sorry to interrupt, ma'am. Sorry to interrupt. We are already
thank you.
minutes late. Yeah.
Thank you so much. Now, Professor Muqtadir will say.
Thank you, madam, for encouraging words. Now I request Professor A.K.M. Muqtadir, sir.
I'm sorry.
Society of Bangladesh. Please, sir.
Thank you very much. Thank you very much. Time is very short.
Yeah.
Professor Abba has elaborated. Hello, hear me?
Yes,
yes, sir. Your voice is audible.
Yeah.
Time up.
No, sir.
Okay, sir.
Thanks.
Thanks.
Conclude the session, sir.
Okay, sir.
Thank you, then.
Conclude the session, sir.
Thank you.
Conclude this session, sir, and thank you.
I congratulate and give thanks to all lecturers, panelists, and everybody to the core of my heart. Thank you very much. And I
Thank you all the chairpersons and speakers.
Thank you. Thank you very much. Thank you.
For such an informative session. By this, we conclude this all for today. Thank you all once again. Stay safe. See you tomorrow. Thank you.
Thank you, Mr. Raj,
Thank you.
for your support during this session. Thank you, Mr.
Thank
Raj.
you so much, sir. Thank you so much.
Thank you
everybody. It
all.
was a nice experience. Yes, sir.
Yes,
Thank you, madam. Thank you.